All right, well, we'll go ahead and get started since we're recording now. All right, well, hello and welcome to Grand Rounds for the Minnesota Regional Spinal Cord Injury Model Systems, or we call it MINSCIMS for short. Thank you so much for joining us today. MINSCIMS is funded by the National Institute on Disability, Independent Living, and Rehabilitation Research, or NIDLR. And they fund this to support innovative projects and research in the delivery, demonstration, and evaluation of medical, rehab, vocational, and other services to meet the needs of individuals with spinal cord injury. Next slide, please. MINSCIMS represents an exciting new partnership among the following Minnesota institutions: Courage Kinney Rehab Institute, which is in Minneapolis, the Mayo Clinic, which is in Rochester, Regions Hospital in St. Paul, and the University of Minnesota. Next slide, please. Our community collaborators include Minnesota Spinal Cord Injury Association, Unite to Fight Paralysis, Get Up, Stand Up to Cure Paralysis, the Paralyzed Veterans of America, United Spinal Association, and the North American Spinal Cord Injury Consortium. So this system collectively provides a multidisciplinary continuum of care for people with spinal cord injury, including emergency medical, acute care, acute rehab, and post-acute services. My name's Angie Philippus, and I'll be the moderator of today's session. I'm a research project specialist in the Department of Rehab Medicine at the University of Minnesota Medical School, and I'm part of the MINSCIMS. Next slide, please. A couple housekeeping notes. The University of Minnesota has organized the CME for today's webinar. Please see the chat information on how to record your attendance and claim CME credits for attending this webinar within 24 hours of the event. This meeting is being recorded and will be posted on the MINSCIMS website. To earn CME credits for today's presentation, please click on the link in the chat. And due to the number of registrants for today's webinar, we've placed phone lines on mute to reduce audio feedback. However, we do welcome and encourage audience participation using the chat and Q&A functions. If you have technical or logistical questions, we ask that you submit those in the chat to Dan Kelly, who will be monitoring that chat. We extend a huge thanks to those working behind the scenes to make these webinars possible. Next slide, please. So the title of today's presentation is Intranasal Insulin to Improve Recovery Following Cervical Spinal Cord Injury. And the speaker for today's webinar is Dr. Leah Hanson. Dr. Leah Hanson is a senior research investigator and senior director of neuroscience research at HealthPartners Institute. A focus of her research has been the development of novel therapeutic delivery methods for the treatment of neurologic disorders, including Alzheimer's disease, Parkinson's disease, stroke, traumatic brain injury, and spinal cord injury. Dr. Hanson currently serves as the site PI for Regions Hospital, part of the MINSCIMS. Dr. Hanson, welcome, and thank you for presenting.
Thank you so much, Angie. It's a pleasure to be here with you today. Before I get started, here are my disclosures. This project is funded by the Minnesota Office of Higher Education, Spinal Cord Injury and Traumatic Brain Injury Research Program, and also that I am an inventor on a patent that is owned by HealthPartners related to this topic. So today I want to talk to you about the work of our lab group, which we've been doing for a very long time. We have been trying to treat neurologic disease of central nervous system disorders, including spinal cord injury. And one of the biggest barriers to doing this is something called the blood-brain barrier. This limits the movement of molecules from the blood to the brain, as you might expect with the name blood-brain barrier, but it's really been a key obstacle in the development of neurologic treatments. There have been several ways that scientists and clinicians have taken to trying to take to overcome this barrier. And you can see those on the picture here. You can do invasive approaches, including intracerebroventricular injections or intrathecal injections. But the pathway our lab has focused on is something called the intranasal delivery method. And this is a direct pathway from the nasal passage where the olfactory neurons live into the brain. And that's the approach we've taken. And I'm going to speak to you today about using that approach with the insulin therapeutic as a treatment for spinal cord injury. So our research group was the first to propose this nose to brain method. This is a non-invasive method as opposed to the other approaches where we are using a nasal spray. This method bypasses the blood-brain barrier. So as opposed to going from the nose to the blood, then the blood to the brain, this pathway is direct. It's very rapid within minutes, and it's along the nerves involved in the sense of smell. By directly targeting the brain versus putting therapeutics into the blood, we reduce the concentrations of that therapeutic and potential side effects of the treatment by using this method. So there are several pathways that drugs can take from the nasal cavity to the central nervous system. The first is along the olfactory nerve. Another is along the trigeminal nerve. Also the vasculature. So there are some molecules that do go into the blood from the nose and travel to the brain if they are able to pass through the blood-brain barrier, like small molecules or lipophilic molecules. There is a perivascular route from the nasal cavity to the CNS and also cerebrospinal fluid pathways. And the property of each therapeutic really determines the method or the route that drugs take. The route that we are targeting is the olfactory and trigeminal nerve route from the nose to the brain. So what really makes this possible is related to the anatomy of the olfactory nerve pathway. In the nose, we have primary sensory neurons, or olfactory receptor neurons, that are exposed to the external environment. The sense of smell is so important for survival. It's evolved for reproduction, for danger, being able to sense the environment, that these neurons are exposed to molecules to sense the environment, but they're also exposed to toxins. So olfactory receptor neurons typically live about 30 days, and then they are regenerated. So there are a lack of tight junctions in the olfactory epithelium. And we have these open pathways that almost act as straws connecting the nasal passage directly along the olfactory nerve into the brain. And really this is the main mechanism that we're targeting in the olfactory pathway for intranasal direct nose to brain delivery. So switching to our therapeutic versus our delivery method, the literature has really been developing that glucose hypometabolism is associated with many central nervous system disorders. And one of the first areas this was identified is in Alzheimer's disease. This is a picture of a PET scan. So this is where a slightly radioactive molecule of sugar, glucose, is injected into the blood and is scanned and imaged. You can see the image on the left of the Alzheimer's patient is more green, there's less red. And on the right, there in a normal elderly adult, you see more red, which indicates higher glucose uptake. And we find that there are many disorders, not just Alzheimer's disease, but Parkinson's disease, traumatic brain injury, and even spinal cord injury, where we see glucose hypometabolism after injury. And this identifies a target for how can we increase this glucose uptake. And insulin is the best way to do this. We know that insulin causes glucose or energy to enter cells. When insulin is administered to the periphery, its path to the brain is really restricted through transporters. So the blood-brain barrier is keeping insulin out of the brain, except in a very regulated way. We do know that in animal studies and in human studies, this is some data from a human study that if you spray insulin into the nose and you do a lumbar puncture and look at the cerebrospinal fluid or the CSF, you can measure insulin in the CSF about 10 minutes after administration. And it's targeted delivery, so we don't see a change in the serum levels. And this is really an important safety feature. You might expect with insulin as a therapeutic, you'd be concerned about hypoglycemia as a potential side effect. But the idea that the blood-brain barrier is actually keeping the insulin inside the brain once it reaches there really allows us to have this direct, safe targeting of insulin to the brain to hopefully counteract that hypometabolism we see in these brain disorders. So the figure on the right side of the screen, you can see a measurement of insulin levels, both versus placebo. So that's the dotted line. And you can see the dark line goes up with in the left, showing the cerebrospinal fluid contains the insulin versus the serum in the figure on the right, where the placebo and the insulin have very similar levels, excuse me. So there have been quite a few, about a dozen clinical trials looking at intranasal insulin to treat different neurologic disorders. There's been about 6 trials in mild cognitive impairment and Alzheimer's patients that have demonstrated improved memory after intranasal insulin treatment. There's been one smaller trial in Parkinson's disease that have showed both improved movement and physical disability as compared to a pre-post baseline. And then there's been about 5 trials in normal, healthy human adults that have demonstrated improved memory, even without memory impairment with intranasal insulin. There's one study in normal, healthy humans that shows an increase in brain cell energy after intranasal insulin. And this includes measured levels of ATP and phosphocreatine, and that's using a P31 MRI imaging. So this is really exciting that we have shown improvement in these symptoms of these disorders after intranasal insulin. And all of these studies have been, very few side effects have been reported. So we're most concerned about changes in the blood levels of glucose or blood levels of insulin. So this is really exciting, and thinking about how we can expand into treatment of other CNS disorders. So our group has worked with ourselves and with collaborators in rodent models of trauma, looking at intranasal insulin, specifically most recently in moderate traumatic brain injury with our collaborators at the Uniformed Services University with Kimberly Burns, and have demonstrated that in a rat model of TBI, that intranasal insulin both increases the uptake of glucose in the brain and also decreases neural inflammation. And even more recently, with the same group has published an improved function and reduction of inflammation in a moderate thoracic model of spinal cord injury in aged rats. The method of protection is thought to be kind of a dual-pronged mechanism. So intranasal insulin, we hypothesize, is increasing glucose uptake. So having more energy for brain repair, brain function, so that we have an improvement in function. And then secondly, suppressing injury-induced or disease-induced inflammation is thought to be the mechanism of action. So in animal studies, we can measure a reduction in glucose uptake that occurs after spinal cord injury. And this reduction is correlated with both neuronal and axonal damage. We know that intranasal insulin increases glucose uptake into cells. We know insulin has anti-inflammatory properties. For example, it reduces the expression of pro-inflammatory cytokines, and it also reduces the activation of macrophages or microglial cells. And so it was really exciting to our group to learn of this spinal cord injury mechanism that the state grant offered us and to propose this study looking in a mouse model of spinal cord injury. We chose to examine cervical cord injury because it hadn't been yet studied in the literature. We know from animal studies, when we deliver intranasal insulin to mice or rats, that we see higher concentrations of insulin in the cervical spinal cord than we do in the lumbar spinal cord or thoracic. So we thought a cervical model would be a really good place to start. Originally, we had proposed 2 specific aims. So this grant was funded before COVID. We did experience some difficulties. So in the end, we weren't able to address our second specific aim. So our aim was to determine the impact of an acute intranasal treatment after spinal cord injury in mice, and that we hypothesized that the insulin would improve both motor and biochemical outcomes when we start treatment acutely after injury. We had hoped to look at a delayed effect, but we'll have to save that for another day and perhaps another animal model. I'll speak to that briefly when we review the results. So briefly, the experimental design, we performed surgery in C57 mice. So these are normal mice. And we induced an impactor injury in the cervical spinal cord. We had originally planned to use a spinal cord compression model with a clip, sent our technicians to do the training, but had difficulties implementing the model, and so had to pivot and move towards an impactor injury. We confirmed the injury at 24 hours using a behavioral measure called the basal mouse scale for locomotion. And then after at 24 hours, we initiated the intranasal insulin dosing. We had a low dose, a high dose, and a saline control, and the insulin was administered daily. And we do that administration through nose drops. So the drop was placed at the end of a pipette tip and was inhaled into the animal's nose. At 7 days, we performed behavior testing. We used the basal mouse scale. We also used a horizontal ladder and an inclined plane test to look at motor function. And we collected tissue after behavioral testing and kept that for measurement of inflammation, as well as some immunohistochemistry. So I'm really excited to report our results. We demonstrated that intranasal insulin significantly improved motor function in these mice after cervical spinal cord injury. Let me explain the graph to you a little if you're not familiar with this type of data. We had 4 treatment groups. We had a sham group. So a sham group is where you perform the surgery, but you don't do the impaction. So it's a measure to show you if there's any if the surgery changes any of the motor function. And that's the dotted line on the top. So you can see day 1 and day 7. And as we would expect, we don't see any change in the score in our sham group. So the higher score means better function. Then we have 2 groups that are treated with intranasal insulin. One is a low and one is a high dose. And then we have a group that is treated with saline, which is our control. We see significance between our sham group and our saline group and our high insulin group. So you can see the plus mark on the screen. I don't know if I click it will change. But basically we see improved function over 7 days with our high dose insulin and are very excited with that result. Another test we did is an inclined plane test to examine motor function. And this is where you place the mouse on a platform and gradually increase the angle. And very similar to the basal mouse scale, which I should have mentioned, that's placing mice in an open field and looking at ambulation and placement of foots. There's I believe a 7-point scale that it's rated on to come up with that score. We saw similar results with the inclined plane, where the intranasal insulin group had a return of function as compared to our saline group. The third test we did was the horizontal ladder, again, looking at motor function as the mice crawled across the ladder, looking at placement of feet and misses. In this test, we did not have statistically significant results because our error was a little bit higher, but you can see the same trend as the other data. The graphs are very similar if I toggle between them. We see in the sham saline group, we see the higher score, the function is retained as we would expect. In our saline treated spinal cord injury model, we see a reduction in that function. And then we see this trend in dose response with intranasal insulin resulting in return of function. So our tissue analysis is still pending. We kept tissue from both the site of injury, from directly above the site of injury and below. We're in the process of analyzing some immunohistochemistry where we look at slices of spinal cord on microscope slides, and we're able to stain them and look for the activation of astrocytes, look at the numbers of neurons, also the microglia and macrophages. In addition to the immunohistochemistry, we are completing our analysis of inflammatory markers. We're using a multiplex ELISA that looks at a panel of about 32 different cytokines that we'll be examining. So what does this mean, and where are we headed? We're very encouraged by our data that shows improved function in these mice. And we really are, while we still have our pending analysis of the immunohistochemistry and the inflammatory biomarkers, we're really pivoting and trying to translate this into clinical trials. We're in a good place with insulin because it's been an approved drug and been used not for intranasal delivery, but for systemic administration for many decades. And because there are about a dozen clinical trials that have already been conducted, we currently have a few approved by the FDA, that the safety has already been established. So we don't have a really high bar of safety or preliminary data that we need to collect in order to transition into human studies. One of the biggest challenges in translating this to use in humans has been the combination of the insulin with a device. There are many different types of intranasal devices. You may be familiar with the sort of metered dose pump spray, or kind of like an Afrin bottle for nasal decongestants. These sprays are like a Flonase allergy medication. They really target just the bottom third of the nasal cavity. When we look at the anatomy of the nasal cavity, the olfactory neurons are in the upper third, and it requires a device to really target that upper third of the nasal cavity. I want to share with you a little about one of the devices that we've been looking at and working with the company. There are a number of different devices that specialize in this delivery, including a device from Vionase, Optinose, Mystic Biosciences, Impel. So this is just one of them. This one is from a company called Cypnose that we've been collaborating with. So on the left, you can see a picture of this device. This is a single-use device. The bottom sort of white part under the blue is a space filled with pressurized air. You place your fingers on the two blue tabs and your thumb underneath the white bottom, and you compress it. And what it does is it allows the sprays to come out at a much more narrow angle. On the top right, you can see sort of this wide angle spray that happens in just a commercially available nasal pump device, and the much more narrow range of the SIPNose device. And many of the other devices have a similar narrow angle. Now, the SIPNose company has looked at deposition in the nasal cavity. If you can compare on the bottom left, if you can see the yellow kind of orangish areas. When you use this commercial nasal pump, you're really targeting that lower part of the nasal cavity. And again, our olfactory sensory neurons are near the cribriform plate, much higher in that upper area. There was an analysis using SPECT-CT, and the images, though not exactly the same method or the same angle, but you can see the really strong orange-yellow staining up in that upper third of the nasal cavity using the SIPNose device. So we have submitted a drug device combination application to the Food and Drug Administration, to the FDA, to do a study using the SIPNose device together with insulin to look at pharmacokinetics. Now, you might be wondering what happened with the dozen studies that have been published. What devices did they use? Why are we going back to the drawing board with the device? Now, quite a few of those studies just used a very basic syringe or basic pump devices. Some were done with specialized devices like with Vinase or with Impel. But there's a really big question, especially in the Alzheimer's community with those trials, is that needing to show that the insulin reaches the cerebral spinal fluid when you put it in a device and you spray it into nose is a really important step before you initiate a clinical trial. Otherwise, you won't know if your clinical trial is not successful. Is it because the device you used didn't deliver it there, or is it because that it delivered it there and it just wasn't effective? And so really that's our next step, is in making sure that we have a partner, a device partner, we can deliver with insulin, and we can demonstrate that the insulin is measurable in the CSF before we go into a therapeutic trial. So that leads us to sort of our next step with what we're preparing for. I mentioned that we've filed this with the FDA. We actually received approval very recently, and it's now pending our IRB approval, or it's under review. So we've partnered with SIPNose. We're going to be intranasally administering insulin in one dose, both using one group of a low dose insulin with 6 people, one group with a high dose insulin in 6 people. We're partnering with Regents Hospital Interventional Radiology to do the guided lumbar punctures, and we'll be taking cerebrospinal fluid samples and serum samples over about 40 minutes, and then analyzing the concentrations of insulin in those samples. This study that we are proposing, we've got approval to do this in healthy adults aged 18 to 35. And this was a small pilot study that was funded by a foundation. We know we want to have more rigor and a wider age range. So we currently have a SCIRP grant that's under review for a larger pharmacokinetic study of intranasal insulin. We have more middle-aged adults, and we also have a saline control group included in that study. That's a translational grant that we submitted together with Kimberly Burns at USU, which also includes some additional rat work to look at both young and aged rats, and as well as male and female rats, and including this pharmacokinetic work that can help us translate into a clinical trial in people living with spinal cord injury. So just in summary, the blood-brain barrier is an obstacle to developing new treatments for central nervous system disorders, including spinal cord injury. Intranasal administration is an innovative approach that's both rapid and non-invasive that can help us bypass this barrier and deliver therapeutics to the brain. We chose to use insulin because of its anti-inflammatory and neuroprotective properties. And we know that intranasal insulin has been shown to reach the spinal cord in animals and animal models at therapeutic concentrations. In the data we collected in this mouse model of cervical spinal cord injury, we found that intranasal insulin improved function, and the analysis of the mechanism in our tissue is pending. We are very excited that the safety of intranasal insulin has been demonstrated in other conditions and in more than a dozen clinical trials, which makes our pathway for translating this into a human study much shorter, and where our team is actively working to do that through this pilot pharmacokinetics study, as well as additional studies in the future. I want to make sure that I acknowledge our research team at HealthPartners Institute and Regents Hospital, as well as Isabel Skarsbrick from Mayo, who is a collaborator on this project. Thank you for your attention, and I'll pass it back to Angie.
Great, wonderful. Well, thank you for an excellent presentation, Dr. Hanson. We will now open the discussion for questions. So please continue to use the Q&A and chat functions to ask your questions. Now I will turn it over to Jared.
Hi, everybody. My name is Jared Fine. I am a research associate at HealthPartners Neurosciences, and I've helped to some extent with this project, and I'll be directing questions to Dr. Hanson from the chat and the Q&A, so feel free to enter them now. We already have one that I can ask to Dr. Hanson. You discussed glucose hypometabolism and are using insulin to combat that. There have been smaller studies looking at diet and keto-based dieting at acute level of injury to assist in recovery. Have you done a cross-analysis between insulin dosing and keto-based dieting?
Oh, that's a really interesting question. I have not done a cross-analysis, and I haven't looked into that literature, but I definitely will do so now. I appreciate you sharing that. I think that's really interesting. And a similar study was done in Alzheimer's disease, looking at a keto diet for treatment. I haven't heard of the combination of the both together.
Okay, some other questions that we have. Can you tell us more about the behavior test to measure motor function in the mice?
Yeah, definitely. And I brought along some of our team measures that did the hands-on work. I'm wondering if Tate, if you're on, if you could run us through the 3 different behavioral tests and describe them in a little more detail.
Sure. Hi, everybody. My name is Tate Bovey. I'm a research assistant here at Neuroscience Center, and worked pretty extensively on this project along with Kate Baltasek. So you went over it a little bit in your presentation, but the 3 behavior tests that we used were the basal mouse scale, the inclined plane, and a horizontal ladder. We did these at the baseline and 7 days post-injury, just to kind of show that at the beginning they were all normal mice, and then at the end there was a difference along with the drug treatment that you discussed. As far as the basal mouse scale, basically all that entailed was 2 observers standing over the mouse in an open field and observing their hind limb motor locomotion. It was on a scale of 0 to 9, with 9 being fully mobile. They had adequate balance and proper stride length, and 0 was kind of the opposite of that, where they didn't really have a lot of motion. The inclined plane was pretty self-explanatory. Basically, we started them off at an angle of 30 degrees and slowly worked the way up until they started sliding off, and this was basically measuring grip strength and balance. Finally, the horizontal ladder, we had a ladder across the plane, and they had rungs that were about half a centimeter spaced, and we would start them at one end and record them while they moved across. We would do 3 trials, and then we would go back and analyze it very slowly, and that had a rating of 0 to 6, with 0 being them not placing their hind limbs on the rings at all, and 6 being a perfect grip while they moved across it. So.
Thank you, Tate. That's a good answer. We have another question about the timing of the intervention. Does that impact the efficacy? What is the time frame post-injury for spinal cord injury that you hypothesize would be most effective? The other diagnoses seem to have less of an acute onset.
Yeah, really good point. The other neurologic disorders like Alzheimer's and Parkinson's are more neurodegenerative. They change over a slower amount of time. We hypothesize that the sooner the better that you administer intranasal insulin. In this study, we started administration after 24 hours at 1 day. The reason we did that rather than doing this immediately after injury, it was important to us with our impactor model that we could confirm we had a deficit, a behavioral deficit. In the C57 mice are fairly small and their spinal cords are small. The impactor surgery is really delicate, that we found some variability in inducing the motor, loss of motor function. And so other disorders, maybe traumatic brain injury and stroke, we've seen results with intranasal therapeutics administered acutely, like right after the time of injury, are very effective. And then we call it the window of opportunity, is how long can we wait and still see an improvement. And so waiting 24 hours and still seeing improvement in motor function after treatment for 7 days was really promising in this study.
Thank you. We do have another question. It is about, can you describe a bit more detail about the impactor method for creating the spinal cord injury model?
Yeah, definitely. I brought Kate, who was one of our surgeons for this model. Kate, can you answer that question?
Yeah, hello everybody. I'm Kate Baltzek. I'm the supervisor of the animal care facility, and I do a lot of surgeries for the groups, and especially Dr. Hanson's group. The impactor model was chosen over the clip method because it is a more reliable method. It doesn't have the tiny, precise clip that you have to place. And we chose the Leica 1 impactor. It is an electromagnetic impactor model that is actuated by a capacitor. So it is actuated, you actually has electromagnetic feedback. So when you are just a millimeter from the dura, it starts a tone, and you can tell that you're just in contact with the dura. So it's very precise and delicate. We also chose the Leica 1 because it has a rigid stabilizer bar system, so it secures the spine very securely, so there is no flex on impact. There is no variability due to flexion of the spine, just to eliminate any variability that way. And the laminectomy is performed at C6-7, and then the impact is done right in the middle of that laminectomy. And so we've found very good results. The mice are a little, there's a little variability due to weight and age. The spinal cord is just a little bit variable, so that's why we chose that model. And then as you can see by the sham procedures, the actual laminectomy does not have much of an impact. The mice heal just great, and they pop right up usually from that procedure. So.
Thank you, Kate. Can you share just a little more about some of the differences in anatomy we found in our C57 mice that impacted or affected the surgery?
Yeah, so the C57 mice have a sharp right angle at C5 and 7, which makes it extremely difficult to get into the area because it goes from dorsal to ventral at a sharp, almost 90-degree angle. And so we had to modify the bars just a tiny bit to reach this area. It is a difficult area, and that we see some myocardial or spine anatomy deformities in the C57 that are not present in other mice. There's a very large hump in the back, and so some variability is due to that, and trying to get at the spine and correct that angle so that we can actually do a safe impact.
Thank you, Kate. We have another question about the insulin trials. Since insulin is so related to diabetes, can people with a diagnosis of diabetes participate in intranasal insulin trials, or would that preclude them from the studies?
That's a really good question. In the initial studies, we did not, and others did not allow people with insulin-dependent diabetes to participate. But they're actually, with all of the safety data that's been collected, we're really showing that intranasal insulin is staying in the brain. It's not affecting blood levels of serum or insulin. The more recent trials actually have allowed people with a diagnosis of diabetes to participate. There even is a study of intranasal insulin in people living with type 2 diabetes in hopes of preventing cognitive decline in that population. So there's a large clinical trial in that population. So that shouldn't preclude people in the long term from receiving this treatment or participating in trials.
Thank you, Dr. Hanson. I'm not seeing any more questions in the chat or the Q&A right now. I will pass it back over to Angie to finish up for the day.
Wonderful. Really great questions. Thank you again, Dr. Hanson, and also thank you to Catherine, Tate, and Jared. And thank you all for attending today's grand rounds. And we apologize if not all questions were answered. So if you have some late coming questions, do feel free to reach out to the presenter directly if you'd like some follow-up regarding your question, or if you do have some of those late questions after you process this a little. The recording of the webinar will be posted soon on the SCIMS website. And as a reminder, please see the chat information on how to obtain the CME credit for attending today's webinar. At the end of the webinar, a brief 3-question survey will pop up. We would really appreciate your feedback. We hope you can join us for our next grand rounds on Thursday, November 3rd at noon Central, where Dr. Stephen Jackson will present Advancing Health Equity, Actionable Strategies to Building Trust. Thank you all and have a great rest of your day.